urothelial lesions are divided into papillary and flat. In the papillary, we have non-neoplastic and neoplastic. In the neoplastic, they can be benign, intermediate, or malignant. And in the malignant, they may be non-invasive and invasive. And when you see the members, you will know non-neoplastic papillary urothelial lesion is polypoid cystitis or reactive polypoid proliferation. In the benign neoplastic is papilloma. In the intermediate category, it is a papillary urothelial neoplasm of low malignant potential. In the malignant non-invasive, what we saw case number 1 is low grade and case number 3 is high grade. And invasive, whenever there is invasion in the bladder, you have to say whether it is in the lamina propria or in the muscle, because treatment is very, very based on this invasive component in the muscle or in the lamina propria. And flat urothelial lesions are AUP or atypical urothelial proliferation, AUS or ATP of unknown significance or uncertain significance, dysplasia and carcinoma in situ. Take a picture of that. And here I use the traffic signal. Red means malignant, yellow means intermediate, green means benign. So when you are seeing cases or when you are taking notes, you can use these 3 colors. All malignancies you mark with red, all benign you mark with green, all intermediate you mark with yellow. That will give you a nice understanding of the pathology. So why we have to know the papillary lesions? As I told you, it's a reactive papilloma, punla, low grade, high grade, non-invasive, then invasive. In the invasive, it's only lamina propria, which is known as PT1A, muscle invasion, PT2. The treatment, it's only follow-up to low-grade non-invasive papillary urothelial carcinoma. Whereas when it is become high grade, we have to go for intravesicular therapy. Intravesicular, sorry, intravesicular, excuse me, take some water. Intravesicular bleomycin or intravesicular BCG. PT1A or PT1, when there is urothelial carcinoma invasion in the lamina propria, it's either intravesicular therapy or cystectomy, depending upon the other findings. And PT2, definitely cystectomy. That's why we have to correctly diagnose, because the treatment depends upon what we are saying. And it's only follow-up. Then why we are having 3 categories? Because of the progression. Reactive papillary proliferation, it never progresses, whereas papilloma less than 5% progress to higher grade. Unlamp 36%, low grade 56, and high grade 70. You can see the number is increasing from up to low. Because of this, we have to classify these lesions. And recurrence rate. When it is high-grade non-invasive papillary urothelial carcinoma, up to 40% can recur. Whereas when it is papilloma, it's only 1%. So this table is also very, very important. I will just put this. You can take a picture. This tells you why you have to correctly classify the papillary lesions. So it's very, very simple to approach bladder lesion, whether it is papillary or flat. When it is papillary, what is the cytology? So this is architecture and this is cytology. No cytological atypia means papilloma or normal. When there is minimal cytological atypia, it is pun lump, AUP or AUS. When there is mild to moderate atypia, it is low-grade papillary urothelial carcinoma or dysplasia when it is flat. When there is moderate to severe atypia, it is high-grade papillary urothelial carcinoma and carcinoma in situ when the lesion is flat. So this understanding is very, 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 very important to approach the bladder lesions. Here I thought I will show you the normal and abnormal lesions. Normal urothelium you can see on the left-hand side, and this is papillary hyperplasia. You see the undulations. but there is no fibrovascular core. It is like knuckles. I don't know whether you can see the camera. It's like knuckles of our fist. There is no papillary process. And when you go to high power, they will be normal with some inflammatory cells infiltrating into them. It may be neutrophils or lymphocytes. So papillary hyperplasia, normal urothelium thrown into knuckles or papillary foldings without fibrovascular core. Papilloma means here it starts like fingers, and this will be very uniform, and the urothelium will be normal, even though architecturally it is abnormal. Cytologically it is normal. So that is papilloma. You can see the normal urothelium in papilloma. Whereas in Punlam, this is a very borderline case, okay? And I never diagnose papillary urothelial neoplasm of low malignant potential because it's very, very difficult to differentiate from low-grade papillary urothelial carcinoma. And when you say low malignant potential, people may ignore. They may not come for follow-up. So I overcall them these as papillary urothelial carcinoma, low-grade. But here the cytological ATPI is minimal, that's what they say. But how will you define minimal? The nuclei are uniform and they lack mitotic activity. Okay, but it's very difficult to apply practically the criteria for Punlam. Whereas the criteria for low-grade and high-grade papillary urothelial carcinoma is very well defined. And here you can see again papillary processes, fibrovascular core, and focal crowding in this low power. Previously, we used to count the number of cells in papillary lesions. If it is more than 7, it is papillary neoplasm. But that counting the number of layers is not practiced now. And low-grade lesions, you can see nuclear overlapping, but the polarity is maintained. Mild ATPI is there. See the smaller cell and larger cells, maybe 2 times. It is not 4 times. And mitosis are very infrequent. As I told you before, when you are looking for mitosis, it is low-grade. And this is a picture where you can see again papillary process, fibrovascular core, and you can see the crowded nuclei. And in the high power, a lot of pleomorphism, okay? And if you start seeing mitosis, the mitosis will be looking at you in high power. So this is a high-grade papillary urothelial carcinoma. So this is a composite picture where I want to put all the papillary lesions in low power, how they look. Normal, reactive papillary proliferation, knuckles, papillary processes, normal cytology, papilloma, minimal atypia Punlam, mild to moderate atypia low grade, severe atypia high grade. And this is the same picture in high power. So I hope you all now comfortable in diagnosing the papillary lesions of the bladder. Coming to flat lesions, there are 4 types. It is atypical urothelial proliferation, flat type, ATP of uncertain significance, dysplasia, and carcinoma in situ. And this table, some of the tables are very good looking, especially for the exams. But practically, when you see, there are only very few points you have to remember. For example, how will you differentiate AUP from flat? It is for flat, they are counting the number of cells. So it is more than 7 cells. Otherwise, everything is normal. ATP of unknown significance, prominent nucleoli, ATPI is there, and lot of inflammatory cells, prominent nucleoli and inflammatory cells, and no mitosis. Dysplasia, ATPI is mild to moderate, and you will start seeing more mitosis. Whereas carcinoma in situ, the ATPI is full thickness, and you see lot of mitosis. So these are all the practical points to help you how to differentiate these 4 flat lesions. And whenever in question, remember I showed you some IHCs, CK20, full thickness in carcinoma in situ, CD44, it will be increased in reactive in all cell layers. P53, it's positive in carcinoma in situ, and P16 is also positive in carcinoma in situ. So this is a composite picture to show you atypical urothelial proliferation, more than 7 layers. Otherwise, it looks normal. Here, ATP of unknown significance. You can see some ATPI, you can see some mitosis, prominent nucleoli, but inflammatory cells are also there infiltrating. And these are all the conditions where these IHCs will be very helpful. Otherwise, they look like dysplasia. IHC will help you to differentiate ATP of uncertain significance from dysplasia and carcinoma in situ. In dysplasia, you can see the ATP are not involved in the full thickness. See the cells in the top, they are looking normal. Whereas in carcinoma in situ, even the top of the cell will be involved. This is like similar to SIN. SIN 1 and SIN 2 will be dysplasia, whereas SIN 3 is carcinoma in situ. And bladder carcinoma in situ, we have different types. First, we have to divide them into urothelial and non-urothelial, where it will be squamous and glandular carcinoma in situ. In the urothelial, it can be usual urothelial atypia. It will be denuded or clinging. Most of the cells will be denuded, and you can see only very few atypical cells just clinging to the submucosa. Pagetoid type, you can see pagetoid cells, carcinoma in situ present as pagetoid cells. I don't have a good example of a small cell, whereas here this is the large cell carcinoma in situ. And again, plasmacytoid carcinoma in situ, I don't have a good example. I'm not able to get it from the internet also. And this is carcinoma in situ squamous type. This is like SIN 2 to 3 or SIN 3. And this is the glandular. This is like AIS in endocervix. So these are all the morphological patterns of bladder carcinoma in situ. Urothelial, non-urothelial, which is squamous and glandular. In the urothelial, it is usual denuded, pagetoid, small cell, large cell, and plasmacytoid.